We'll move on now to Allison Gregory. I'd like to introduce Allison, who you all know is genetic counselor based at OHSU, Oregon University, who will be telling us about INAD-ready or PLANready. Thank you, Allison.
Thanks, Manju. Let me make sure I've got my presentation going here. So can somebody let me know if you can see everything and hear me okay?
Yeah, we can hear you good and see your presentation. All looks good.
Great, thank you. So for me, it's still good morning. I'm glad to be here. Thank you, Manju, for the introduction. And I'm gonna jump right in because my time is pretty limited. So our PLANready natural history study, back at the meeting in Skamania a little over 3 years ago, we were planning this study. We've since opened it to enrollment and have had it running for nearly 3 years now. And it involves both a parent report component and then also data that we collect directly from healthcare providers, usually physical therapists. And everything is done remotely. So, again, this was kind of leading up to our co-AZ trial and testing the waters. Can we do this more efficiently at a lower cost remotely? Will it work? Is it better doing it fully online or partially by phone, that sort of thing? And this one is really mostly done online. So heading right into how we collect our data. For INAD in particular, we collect data on both INAD and atypical NAD in this study. We're collecting data every 3 months for children who are 5 and under, and that's because we felt it was really important with the rapid progression in INAD. We wanted to try to capture both ends of the tail, meaning capture data as they were still making developmental gains, go over the hump, and capture data as they start losing skills and also maybe becoming positive for other INAD disease milestones that we've identified. Once kids hit that 5-year mark, then we start doing 6-month visits instead, because we feel like, at a certain point, they're sort of bottomed out to where there isn't a lot of change happening anymore. And then for those atypical cases, their progression is more protracted anyway, and we didn't feel it was as important to be looking every 3 months versus 6. In this study as well, the parents of a deceased child can do a single visit and upload that. So we collect data prospectively to capture gain and loss of milestones. We also added what we call a point of entry retrospective visit. This was recommended by our statistical partners at Washington State. So when I enroll a family, I ask them to think back to the point where they first suspected something was going wrong, or maybe they were first referred to a developmental specialist or a neurologist. And we try to get records from that time and extract the same data fields so that we have an earlier point to compare to, rather than just taking it at the point when they enroll in the study. And finally, like our BPAN and PCAN natural history studies, are what we call disease milestones, are milestones that we've developed based on our expertise, getting input from other experts, piloting with families, and then sort of adjusting them over time if we need to. So this is just an example of what it looks like online. Everything is done through that REDCap platform that Puneet described in her BPAN talk. So this is, what the screen looks like for a family. We've divided our data collection into motor, social, language, and disease-specific questions. These are the personal social skills questions that we ask, and these are being asked repeatedly every 3 months to every 6 months. We also have some patient-reported outcome measures, or in this case, parent-reported outcome measures that we chose specifically because we thought that they dovetailed well with infantile and atypical PLAN. Obviously, for the infantile cases, parents serve as proxies. For some of the juvenile subjects, especially the ones who aren't very far along in their disease, they actually answer these questions themselves, and they have a different set that they answer. And our outcome measures were selected because they're relevant to PLAN. They've been normed in both normal and disease populations, and they can be scored pretty easily. So the main one that we use in the infantile cases is this infant and toddler quality of life scale, which has been published. Anybody who wants a reference, I can give it to you. But it was developed for children 2 months of age to 5 years of age. So that's the population in which it has been normed and it's supposed to be used. And it looks at health as a state of physical, mental, and social well-being, with 9 sections that cover a spectrum including behavior, temperament and mood, pain and discomfort, physical abilities, and satisfaction with growth and development. And I'll show you that in a minute. Then, for the juvenile cases, we, this isn't appropriate, a toddler questionnaire. So we do use a series of toolbox and promise tools that we've used in other studies, covering anger, anxiety, peer relations, some of those things that are more relevant to these kids who are actually going to school, who have language, who are doing a lot more. So I should mention for the ITQOL, we're using it in kids with PLAN, particularly classic disease, who are older than 5. It's not normed for that group. But when I show you some of the sample questions, you'll see it's actually quite relevant. I've been really happy with it as an outcome measure. So I'm interested to see with our statistical analysis if it's something that could be used in a trial. So here's an example of what it looks like in our REDCap system when a family answers these questions. The overall question is, how satisfied are you with your child's, fill in the blank? But it covers responsiveness to others, motor development, physical growth, feeding, sleep habits, bowel habits, general temperament. These are all things that we feel are very relevant to INAD. And then we also get data from healthcare providers. And we did this for 2 reasons. One is we wanted to check whether their answers were different than the families, and this is a good way to compare. Also, there are some questions that are a little technical to ask families. We don't want to ask the parents about spasticity versus dystonia. Some of those things are difficult. So usually it's a physical therapist completing this for us. They rate milestones, developmental milestones as well. This is just an excerpt of the disease milestones that we ask them about. And the physical therapist, because they usually see the kids on a regular schedule, and it's often weekly, they've just been fantastic about getting this back to me. Sometimes I don't even have to remind them. They send it before I remind them. But you'll see here, they do give us information about tone and about how things are changing over time, some of the ophthalmic findings, and then some of the main disease milestones. So I talked about statistical analysis in more depth with my PCAN talk. I'm not going to go into it again here since I have quite short time. Other than to say that, because of the trajectory of INAD and how they gain and then lose, we think this could be a really good way to analyze that data. And we're hopeful that we could develop curves specific to INAD where an intervention would change the curve and could be used in a trial. We did do a feasibility study back in November 2019 with our collaborators, with Dr. French's group. So that was about just under 2 years into this study. And we gave him a subset of data from, I think it was 9 subjects. They built 2 different models. And the bottom line was both models, sometimes he'll model it one way using the latent growth curves. And then he'll say, okay, well, if you can't enroll quite this many people, could we do additional Bayesian analysis that might be useful to get us there? So when they modeled these things, the recommendation was to try to get at least 40 subjects with at least 3 time points. And what we found so far is the 3 time points is no problem. We've got far more than that on people. The challenge has been the 40 plus subjects. So here's a snapshot of our current status. And I wanted to point out, first of all, that funding for the last 2 years specifically has come from the INAD Cure Foundation. I know that Lena Panwala is attending this morning, and we can thank her directly for that. It's been great. We've actually had a contract with them for the last 2 years because they see the value of this work, and it's hard to get this kind of work funded as a standalone. So currently we have 36 subjects enrolled. 4 of those are the single deceased visits that I told you about, where a parent of a deceased child can come in and do a one-time entry, and those were all infantile cases. We have 19 cases of INAD. Sorry, it's my mouse. 9 of them are from the US, 10 are from other countries. Then we have 13 atypical or juvenile cases. 5 of those are from the US. And I'll circle back to that in a minute. 3 of the subjects have died in the course of the study, which is essentially meeting the final disease milestone when we talk about the disease milestones that we measure. And then 2 of them have dropped out. That was 1 infantile and 1 juvenile. Of this data set, we took Manju's pro forma for her ongoing natural history study, and we've provided as much as we can in a de-identified way to share, to support that study, to do anything we can to move clinical trials forward. So I just wanted to point that out. And even though this is all, mostly prospective and doesn't involve MRI or some of the other medical record data, we do have that in our bigger repository for many of these subjects. So we were able to pull from different places and share data for that study as well. So getting back to our subjects, one thing Manju mentioned in her study, that when they pulled from TIRCON cases, I think she said they had 185 classic and 13 atypical. Well, I have 19 classic and 13 atypical. Why would that be? And frankly, I don't have as many classics as I would like, and that's been one of the biggest challenges with this study. Our general impression from talking to families, from trying to understand what's going on, from talking to the dropouts, I think maybe the families with classic children don't perceive any direct benefit from this. It's so rapidly progressive. When I talk about a natural history study and it's a 5-year study and looking to be trial ready, I think they feel it's not as relevant for them, which is really unfortunate. But I do think, these visits are hard. They do them every 3 months. I think it can be a little sad and depressing or daunting to keep just marking things that they've lost, or how maybe dissatisfied they are with their child's health. And I suspect that's why we have so many juvenile cases, that because of that protracted, more slowly progressive disease, they may feel more hopeful, they may see more benefit, to themselves from doing this. And I'm not quite sure how to turn that around. We've been trying really hard, and we've been partnering with INAD Cure to try to recruit as people are diagnosed, and we're hoping that will help. And then just at the bottom to point out, so our earliest enrollees have up to as many as 12 visits at 3-month intervals, and most of the people in the study have done about 4 to 8 visits. Some of those are on 6-month intervals instead of 3. But what I will say is, for the 19 infantile cases that we do have, these people are really committed. So while the number is small, the data is really high quality. They are on the ball every 3 months. We're capturing all the little changes that are happening in their developmental milestones and their attainment of what we call INAD disease milestones. And then finally, just a few conclusions. I already talked about number 1. I already talked about number 2 also. And number 3, I think we've had good luck designing these remote trials, not just luck, we've put a lot of thought into it. And I think we've adjusted as we go. This was our second one, so we learned some from the PCAN study. We've done a really nice job with our platforms for collecting data and having families enter it themselves at their leisure, after their kids are in bed, online, however it works for them. But we're definitely still learning. And I'd like to thank my team at OHSU and all of our collaborators who have helped work on this study. And with that, I can take any questions. Thank you.
Thank you, Allison, for such a lovely talk for a very important subject. It was really nice to hear it and how well it's working. Any questions, please post them on the chat. Just to confirm, this is like PLANready in that not just US participants, you have IRB cover for enrollment of patients from anywhere in the world to participate, for you to be told about them.
Several people from other countries participating. It's lovely that many people in other countries speak and write English so well. We've been able to leverage that. We don't have it translated into other languages yet. That's a pretty daunting next step, and to think about which language to do first. We've been very lucky to have people in other countries participate.
And I agree very much with this. So every family we see, we'll mention this study, and it's on our clinic letters and everything. The issue is, I think, exactly like you say, the grief process for INAD. I'm sure families here at this meeting will understand when I say that the families come with photographs and videos of the children when they were very different children, and there's a huge grief process. So the concept of participating in a trial, but I can't emphasize how important this is. This is in the absence of any biomarkers that are really reliable, this study is more crucial than anything to get us to clinical trials. So I can't emphasize that enough.
I agree. And I think the families who are enrolled really get that. And I've been really impressed with their commitment. We just need a few more who feel the same way.
Any other questions? So there's no other questions on the chat, but please email or ask Allison on the group chat for any questions, and we can discuss further in the roundtable. Thank you, Allison, again for a lovely talk.